Good afternoon, everybody. Welcome to the TUGSS EGS session today. It's 2 o'clock in London, but of course we've got people dialing in from across the globe. I'm pleased to introduce my former trainer. I spent some time training in Dundee, and Murray Flett, who's a consultant vascular and endovascular surgeon from Ninewells Hospital in Dundee, has agreed to accept the invitation to deliver a talk on acute mesenteric ischemia. So over to him.
Thank you very much, Michael. Thank you for asking me to give this talk. The focus is going to be on acute mesenteric ischemia. I'm going to talk a little bit about chronic and acute on chronic mesenteric ischemia because we probably see that presenting to us the people with background of mesenteric arterial disease who present with acute on chronic symptoms. We probably see that more. We do see that far more often than the acute embolic related patients, and I think that's because most patients, at least with diagnosed atrial fibrillation, are anticoagulated these days. So that is less common than it used to be, but the acute on chronics are probably make up most of the patients that we see as an emergency. So I was hoping that would advance my slide. Okay, can you see the full slide, or is part of it masked by?
I can see chronic mesenteric ischemia.
Yeah, okay, dope. If I can minimize the bar on the right, then I can see all my whole slide. There we go. There it is. Yeah, so we'll kick off talking a little bit about chronic mesenteric ischemia. That typically these patients are referred to the vascular service, obviously a vascular surgeon from another specialty. Is relatively rare to come from primary care, often referred to gastroenterology with chronic abdominal pain and weight loss, often referred to general surgery as well, and then after investigations, onward referral to ourselves. So as I'm sure you know, it can be a progressive debilitating disease. The most common cause of chronic mesenteric ischemia is atherosclerotic mesenteric arterial disease itself. And typical features: postprandial pain, weight loss, food fear. And quite often we see these patients in an emaciated, hectic state by the time they have either sought medical advice or they've had other diagnoses excluded. So it is quite chronic mesenteric ischemia is quite rare. It actually forms a very small part of our practice, less than 1%, so 0.5% of all vascular procedures are accounted for by mesenteric bypasses. And all other specialties, primary care doctors, gastroenterologists, general surgeons probably see them far less frequently than we do. So it's not a common diagnosis, and I guess the key to making the diagnosis is having an index of suspicion. Patients don't do well with a delayed diagnosis, and diagnosis is a challenge. And like I said a second ago, often delayed while other causes of abdominal pain and weight loss are correctly investigated, and it can become a diagnosis of exclusion sometimes. Less often these days than in the past. So I'm sure I don't have to go through this in too much detail, but the traditional teaching has it that to develop chronic mesenteric symptoms, you have to have a disease in at least 2 of the mesenteric arteries. So 2 out of 3 of the celiac axis, the SMA or the IMA. And the reason for that, I think, is the extensive collateral network between these 3 territories. The gastroduodenal arcade collateralizing between the celiac and the SMA, and the arc of Riemann, I guess, and the marginal artery communicating with the SMA and the IMA. So although autopsy studies show that mesenteric arterial disease is common, the symptomatic scenario of chronic mesenteric ischemia is much less rare, much less common, far rarer, I think, because of the collaterals, extensive collaterals that are often present, and as well as auto-regulation of splanchnic blood flow and whatnot that can often lead to patients not having any symptoms at all. This is just a catheter angio in quite an interesting patient that had a mid-aortic syndrome, so had the a congenital syndrome with atresia of the mid-aorta, and had that replaced with a Dacron tube graft as a child, and ultimately developed a significant disease within her native aorta as well as in her mesenteric vessels. So this is a selective angio from just at the IMA origin, showing a very large IMA, which is has this very large collateral coming from the left colic branch, I think, this tortuous meandering artery, so-called arc of Riemann, and is then refilling the SMA distal to its occluded origin. And that lady's celiac axis was also occluded. So her entire, I just go back through these images, her entire gut was being supplied by an IMA. That this image doesn't show it, but there was very serious disease in the aorta itself proximal to that IMA origin, a big mass of calcium obliterating the lumen of our aorta almost, so presented with chronic mesenteric ischemic symptoms due to a compromised IMA that was perfusing the entire gut because of the occlusion of the celiac and SMA. I'm just going to come off that presentation just for a second and just show you some images of how we managed this lady. So we thought about stenting the aorta, but we didn't think that was durable. This was still a young patient in her late 30s, early 40s. And we couldn't help noticing on the CT that the iliac artery, common iliac artery, you can see here slung with a blue sling, and the inferior mesenteric artery were immediately adjacent to each other on the CT. So we carried out a laparotomy, opened the retroperitoneum, and indeed there they were lying side by side. And the options in this case would be to a short graft, probably a Dacron tube, communicating between the iliac artery and the inferior mesenteric. But we chose to, it's just a similar view down into the pelvis, those two arteries side by side. What we did is actually we transposed we divided the origin of the IMA, transposed it across to the common iliac artery. We actually, this is a vein patch because the common iliac artery didn't appear to be diseased on the CT, but it was actually quite thickened and diseased. So that's a vein patch and the inferior mesenteric artery transposed onto the common iliac. So yeah, I could not incorporate that into my PowerPoint, so we'll ditch that. Go back to the PowerPoint. If anyone's got any questions, I have to minimize the panel on the right so I can see my slides, but if you see any questions, Michael, maybe you could draw my attention to it, and I'd be happy to.
I've got my colleague, Alison Bradley, so she's going to man the questions. There's a little chat icon, and we'll cover them at the end. Okay, no, that's absolutely fine. Okay, thank you. Anyway, hopefully that makes sense. Quite an unusual presentation, but just to highlight the massive collaterals between that we see enlarging hugely in these patients with chronic mesenteric disease to compensate for occlusion of one or more of these arteries. So, yeah, as we were saying, symptomatic chronic mesenteric ischemia. It's actually common to have mesenteric arterial disease. 18% of
patients over 65 years are found to have significant disease in their mesenteric vessels. That's a study that was in cadaveric study. Excuse me, I'll just go back. As we said before, for the reasons we've discussed, symptomatic chronic mesenteric ischemia is far more unusual and not a large part of our practice, not a large part of anyone's practice. I think that's possibly why can be delays to diagnosis quite often. Underdiagnosis is potentially a factor as well in identifying patients who do have symptomatic disease. So we'll move on to acute mesenteric ischemia, which you may be more interested in. So a surgical emergency, again, it requires prompt diagnosis and intervention to prevent bowel infarction and death. And a delay in diagnosis is associated with poor survival rates. And if you look at the literature, the survival is not good in patients with acute mesenteric ischemia, 60 to 80% mortality rate. That is a little bit of a historical paper. I would like to think that we're doing better. I think we are doing better. I don't have data to present to you locally. We did look at this back in 2016. Unfortunately, I could not find our abstract, but we are doing significantly better than this awful mortality rate of 60 to 80% nowadays. But there's still a significant mortality rate of 30 to 40% at least. I think the improvements have been, having a low threshold for making that an index of suspicion, if you like, for making the diagnosis, CT, dual phase CT scanning in most of these patients who have present with acute abdomens, and close liaison, between general surgery and vascular. I'd like to think that in this hospital we work well together in that regard. Most of these patients do present to general surgery in the first instance. And there's no doubt that early diagnosis and intervention is the key to a successful outcome. So in terms of the causes of acute mesenteric ischemia, again, it's a little bit of an old paper, arterial embolism, 40 to 50% in the early 2000s. That is diminishing. And I think it's because most patients with diagnosed atrial fibrillation are anticoagulated in the community. We do still see it, but I would say the second group here are becoming far more common, and I think that's related to elderly population with people who do have mesenteric arterial disease. They are living longer, and their arterial disease is worsening as a result, and sooner or later they will present with chronic symptoms. And what we see very often in patients with chronic mesenteric ischemia who have had a delay in diagnosis or a delay to intervention, not only do they become steadily more emaciated and cahectic, but sooner or later they will present with acute mesenteric ischemia, acute on-chronic symptoms. We see that time after time in patients who've had a delay to diagnosis or intervention. And I think that's probably our biggest group of patients that we treat with acute mesenteric ischemia these days. The non-occlusive group and venous thrombosis are comparatively much rarer. The non-occlusive tends to be critically unwell ITU patients who are compromised hemodynamically or with multi-organ dysfunction, who have got existing arterial disease, who can present with acute or chronic symptoms. And venous thrombosis is a much smaller, very rarely see venous thrombosis. I was going to discuss some cases just to highlight some of the points. So first patient, 76-year-old lady, presenting to the A&E department, a 24-hour history of acute onset central abdominal pain associated with vomiting and diarrhea, having previously been well. Her past history included diabetes. She had mitral stenosis and atrial fibrillation. She was on digoxin for her AF and anticoagulated with warfarin. On examination, she was tachycardic, blood pressure, oxygenation maintained. Her abdomen was soft with non-tender normal bowel sounds. Her blood tests, moderately elevated white cell count, an INR that, so prothrombin ratio, if you like. If you're not familiar with INR, is subtherapeutic for treatment with atrial fibrillation. She's got a CRP, which is elevated, or inflammatory markers are elevated. White count moderately elevated, CRP high, and slight elevation of her amylase. And ECG confirmed she was in atrial fibrillation. So this lady was admitted under the acute medical team. A diagnosis in the emergency department was made of infective gastroenteritis. So ongoing symptoms of abdominal pain, developing generalized tenderness throughout her abdomen. Still no signs of guarding or rebound or peritonism, but ongoing symptoms and a deteriorating picture. Tachypneic. 48 hours after her admission, a surgical referral was made to general surgery, 11:30 p.m. Now, if I'm teaching our trainees, I ask them, what would you do at this stage? And almost all of them say an immediate CT scan, which I'll show you in a minute or two. So at this stage, her arterial blood gases are reasonably unremarkable, a low PCO2, suggesting maybe sort of early compensation of developing metabolic acidosis, but largely unremarkable. This is her CT. I'm just going to scroll through the axial slices, starting just at the level of the celiac axis. That's there. You can see that's patent, dividing into hepatic and splenic arteries. And there, sorry, I'm just going to, yeah, celiac is there. SMA origin is there. Healthy looking normal proximal SMA. Filling defect 3 to 4 centimeters from the origin of the superior mesenteric artery. It's a sagittal view, sorry for the quality of the picture, but normal looking celiac axis, normal looking ostium of the SMA, and an occlusion 3 to 4 centimeters distally, and with reconstitution of the distal SMA. No specific features on the CT that suggested significant bowel ischemia, but I think at this stage we're in little doubt about the diagnosis. So this is a typical picture of an embolus to the superior mesenteric artery. Typically, native disease involves the ostium of the vessel. I look at it as a aortic disease that's involving the ostium of one or all of the mesenteric vessels. But her mesenteric vessels look pristine, 3 or 4 centimeters, usually at the level of the middle colic, because there's a caliber change in the SMA at that level, and that's typically where an embolus will get stuck. So that really is pretty diagnostic of an SMA embolus. Axial view just showing that filling defect, almost with a sort of halo of contrast surrounding it. But fairly pristine looking aorta and native vessels. So the key points in this case, I guess that early symptoms and signs are quite often non-specific with acute mesenteric ischemia. So the typical textbook description is usually describes people with severe abdominal pain with an absence of physical signs on examination of the abdomen. And certainly that applied to this lady. It was abdomen soft, non-tender on admission. And a delay in diagnosis like this can often results in poor outcomes. So there's no doubt that the ischemic insult will deteriorate over time, particularly profound ischemic insult with an embolus to a normal vessel. There's been no slow development of atherosclerosis over time, so collaterals will not have developed. So this situation of an acute embolic event, the presentation is usually far more precipitous with a severe ischemic insult. And the delay will result in ongoing ischemia and with the risk of bowel infarction. And I think also if patients are revascularized after a delay to diagnosis, the post-operative course is often far more stormy with this severity of reperfusion syndrome being much worse the longer the ischemic insult has gone on. So there's a long duration of ischemia, a risk of bowel infarction, and then a very stormy period with a reperfusion syndrome. So this lady had a surgical embolectomy. She did survive despite the delay to diagnosis, but significant morbidity. She had a second loop laparotomy, which we don't regard it as mandatory, but we have a very low threshold for a second loop in these patients. If they're after revascularization, there are areas of bowel that are questionable but not frankly necrotic, then we will close the patient and they will go to intensive care for support, and usually at 24 hours we'll bring them back to have a second look. And I think most people would regard that as being extremely important. In this kind of situation, if her bowel looked diffusely ischemic at the initial laparotomy, potentially salvageable. So we went ahead and did her SMA embolectomy. There were still some patchy ischemic looking areas, but nothing frankly necrotic after we'd revascularized it. So chose the second look rather than resection at the time. So no bowel resection was required. This lady had a prolonged stay in intensive care, ventilatory support, inotropic support, renal dialysis, and parenteral nutrition. Was weeks in hospital, but subsequently made full recovery. I think her stormy post-operative course was undoubtedly related to the delay in diagnosis. And we get this hammered into us as vascular trainees. It was a long time ago for me, obviously, but the blood tests are not usually helpful in making a diagnosis. Elevated inflammatory markers, sometimes elevation of amylase they're non-specific, and they often occur late in the course. Not at presentation quite often, but develop over time with sometimes after the bowel has actually infarcted. Elevated lactate, also a late finding, and we usually get very anxious when we see that because it does imply that there's a profoundly ischemic gut and possibly infarcted bowel. Again, and metabolic acidosis, relatively late finding. So we don't rely on these blood tests to make a diagnosis because many of them are non-specific and occur relatively late in the presentation. That's not to say if there are patients that we are unsure of a diagnosis that we are monitoring, we will obviously be keeping an eye on all these markers as well as reassessing the patients clinically. But the key is CT, dual phase CT. There are quite a number of studies that show that CT and, well, an arterial phase and a delayed portal venous phase has a high sensitivity and specificity for diagnosing acutely ischemic gut. I must admit that is not generally our experience. You know, the CT angiogram is crucial to look at the mesenteric vessels, whether there's osteal disease, native vessel disease, or evidence of an embolic problem. But in terms of the changes seen in the gut itself, fat stranding being the main thing, edema, reduced enhancement in the portal venous phase. That, you know, we have in my practice at least, I've not found those to correlate very well with the findings that we actually see at laparotomy. But I'd be interested to hear if anyone else has got any different experience of that. A little bit of anatomy. So we actually typically will, there's the SMA and just at the, you know, as it emerges underneath the pancreas, right at the root of the mesentery, we usually expose it more distally in the mesentery. You know, partly because, I mean, this would probably be our exposure for, if we were considering doing a mesenteric bypass onto a healthy piece of healthy segment of the superior mesenteric artery, distal to the ostium, but not so distal that we're anastomosing onto a smaller and smaller artery. So this would be our approach if we were doing a bypass. If we were doing an embolectomy, we would expose it more distally in the mesentery, simply because the emboli are usually lodged, you know, 3 to 4 centimeters distal to the origin, and it's more satisfactory if we are just distal to that level to remove clot. We will make a transverse arteriotomy in the artery and use a simple Fogarty balloon catheter, typically to sweep it proximally to establish inflow and to sweep distally to make sure there's no further debris distally. And then that transverse arteriotomy is just closed with simple interrupted Prolene sutures. And, you know, it's technically relatively straightforward operation to do. Technical results are often great, but because of the severity of the illness with the patients, there still is this high mortality risk. They are often elderly and comorbid patients, as well as having had the ischemic insult of acute mesenteric ischemia, followed by a reperfusion syndrome that can be extremely stormy. So I'll move on to second case. This is a different scenario, which we see not infrequently. An 82-year-old lady that presented to us with a 9-month history of postprandial abdominal pain associated with marked weight loss, chronic diarrhea, food fear, and really quite a malnourished, emaciated state when we saw this lady. She's quite a high-risk patient with a number of comorbidities. She's a smoker. She's got disabling intermittent claudication due to peripheral arterial disease. She's got COPD, ischemic heart disease, and a degree of cardiac failure. And she's in her early 80s. Really quite emaciated, BMI 16. Other than that, no other real abnormal findings on clinical examination. Blood test, she's got a high white cell count, interestingly. Moderately elevated inflammatory markers. Her CRP is high. Everything else is non-specific. At this stage, this lady's, I think actually she might have had, if I recall, concurrent chest infection, which may well account for her high inflammatory markers at that stage. I think they resolved after treatment of her chest infection. So there was no real specific abnormalities. Her albumin was extremely low in the mid to low teens, and she was emaciated. The main findings. So yeah. So I was going to show you her imaging next. Just bear with me for a second. We'll come back to that slide. Yeah, this may be in the wrong order. It is. It's unfortunate. Bear with me for a minute. I'll see if I can find her CT imaging. Yeah, for some reason those slides are all hidden. I will unhide them. Apologies, folks. Bear with me. So yeah, blood tests, CT angiogram. I'm just going to scroll down through the axials of this CT angiogram. I will stop it and go back maybe. You can see there's an extensive calcification of the aorta itself. The infrarenal aorta is almost obliterated, the lumen with calcium, as well as both are common iliacs. So, and remembering this lady had significant disabling claudication symptoms, and really, and that's the segment of infrarenal aorta that is the lumen is almost obliterated with a large calcified plaque. I'll go back up to the. So the celiac axis is there. There's a lot of calcium at its origin, but in actual fact, we didn't think that it was a significant stenosis at the origin of the celiac. And in fact, a duplex ultrasound scan confirmed that there was very good flow with no significant narrowing at the celiac origin, despite that calcium right at its ostium. If you come down slowly through the aorta, that's, I think that's the origin of the superior mesenteric artery. They're just anteriorly on the aorta. It's just a lump of calcium. The superior mesenteric artery is occluded at its origin. I'll just keep scrolling down slowly if I can. Yeah, so it's occluded with heavily calcified plaque. But there is contrast filling distal to that calcified occlusion, collateralizing from the celiac. And then just to highlight the diffuse severe calcific disease throughout the whole of the infrarenal aorta that's just obliterated there, and then both common iliac arteries also. So I think we can show you some sagittal reconstructions to look at that SMA. You can see the calcium at its origin there, and as you come through, you can see that ribbon of calcium that's occluding the lumen, but a decent looking superior mesenteric artery distal to that. So this lady is a real challenge to treat. You know, she's elderly. She is in an emaciated state. It's a coronal view of her aorta, just to highlight how horribly calcified the aorta, almost all of the aorta and the iliac arteries are. So yeah, a real challenge to treat. There's no real option for a bypass here, even though the distal SMA is a good quality vessel. The challenges of taking a bypass anywhere off the aorta or the iliacs, for that matter, it would not be technically possible due to the severe calcified disease. Also, just to say that she had an attempt to stent her SMA from upper limb access, but in actual fact, she had severe upper limb arterial disease as well, and it was not possible to get access down into the aorta from upper limb access. So no, we didn't think there was a bypass option. We didn't think there was a percutaneous stenting option. So after a lot of deliberation, we had planned a laparotomy for this lady in order to place a retrograde SMA stent. So that's cannulating exposing the distal SMA, cannulating it, and getting a wire retrogradely across that proximal SMA occlusion, and then stenting across it. And this is quite it's not an uncommon thing that we do in patients who, like this lady, had no other options whatsoever to revascularize her gut. But literally 24 hours prior to a planned admission for this procedure, she was admitted as an emergency, acute abdominal pain, high inflammatory markers, lactate was moderately elevated, metabolic acidosis, an acute abdomen, tender, right-sided guarding in the right side of her abdomen. Repeat CT scan was unchanged, essentially similar appearance of the SMA with that calcified occlusion. No real specific features of acute mesenteric ischemia identified on the CT. But in this kind of situation, with this presentation, we have a very high suspicion that she has developed acute on chronic ischemia and is in risk of infarcting her bowel. So she was taken to theatre. She had a laparotomy, diffusely ischemic looking bowel, and it'll just go through what we do. So we to treat these lesions when there is no bypass option, we're cannulating the distal SMA that's exposed in the small bowel mesentery. That's just an initial angiogram showing the injection into the distal SMA with an occlusion proximally. That's an anteroposterior view with the imaging. This is a lateral view. So you can see that there's a 3 or 4 centimeter occlusion of that proximal SMA, horribly diseased aorta, but there is inflow. There's the infrarenal aorta is almost completely occluded, but there is some inflow, very irregular, heavily calcified aorta, but there is inflow. So we can get a guide wire. It's much easier also to get a guide wire because we're puncturing so close to the target lesion, and we put a catheter across that. You probably can't see it, but there are markers on it to tell us what length of stent we need. We place a balloon-mounted stent, which you can see being deployed here. It's a stainless steel stent mounted on a balloon catheter, and then an angiogram carried out, showing that we have recanalized that. That's a lateral view and then an AP view. So once this lady had her the SMA stent placed, it did become clear that the right colon was not going to recover. So she had a right hemicolectomy and an ileostomy, managed in intensive care. That's an AP view of completion after placement of the stent. You can see there in the proximal SMA. In hospital for weeks, but eventually was all sorts of complications, mainly chest related to her smoking and her COPD. But I think her, against the odds, she did survive, went home, recently returned to the outpatient clinic, but is, I would say, on the road to recovery. And this was done in January this year, and she's nowhere near her baseline functioning, preoperatively. Just a case that highlights this horrible tendency that these patients have, these chronic mesenteric ischemic patients, to sooner or later they will all develop acute symptoms with a very high risk of infarcting their bowel. Quickly just go through her post-op CT, showing that calcified aorta, celiac coming off there, and then the SMA stent. In amongst all that calcium is patent. Some sagittal views demonstrating the same thing. These stents, I'm not going to show that case. These stents do require careful follow-up because although the evidence suggests that there's no good quality evidence comparing surgical management with endovascular treatment. What evidence there is all poor quality, but suggests that you do get similar results in the long term, whether it's endovascular or surgical bypass or treating chronic mesenteric ischemia. This lady has that chronic picture, although she presented acutely The stents require very careful follow-up, and we will follow them up closely in our vascular lab, because there's quite a high risk of restenosis in these patients. Yeah, I'm going to skip over that case. Similar, maybe. So just to highlight again, patients will often present with acute symptoms after a chronic debilitating illness if there's a delay to intervention. And sadly, this lady literally did that 24 hours before a planned elective procedure. Endovascular treatment is well established in the treatment management of patients with chronic mesenteric ischemia. 0 randomized controlled trials comparing endovascular with surgery, poor quality evidence. But there's a suggestion that depending on the patient, it's an individualized decision-making process, depending on how fit the patient is, their life expectancy, their comorbidities, and the feasibility of treatment. In this particular lady, there was no possible option of bypass. And retrograde stenting performed at laparotomy is a get out for, and really the only feasible means of revascularizing some of these patients. One last case, quickly go through. A lady that was referred to us from another hospital a number of years ago now. She'd been admitted to this hospital with severe abdominal pain, 3 to 4 day history, vomiting, diarrhea. This lady was known to have a past history of peripheral arterial disease as well as abdominal aortic aneurysm. She had previously had a thoracic EVAR for a thoracic aortic aneurysm. And this lady had a mild pyrexia when she was admitted, a little bit hypertensive, a little bit tachycardic, and a diffusely tender abdomen, generalized guarding. I think the diagnosis was made of diverticulitis, which was managed with broad spectrum antibiotics and managed conservatively at that stage. Blood tests, non-specific elevation of white cell count, CRP, and yeah, blood gases. She's got I think a compensated metabolic acidosis there. So potentially should have been alarm bells ringing, particularly with her history of arterial disease and aortic disease. She was managed conservatively for 48 hours. Then she was transferred to our hospital. And the reason that she was referred to us because she developed an acutely ischemic limb, a very ischemic looking limb. So when this lady came to us, it was clear that she was gravely unwell, not quite moribund, but really sick, hypertensive, tachycardic, struggling to maintain her oxygenation. Blood tests were all deteriorating. We knew that this lady had chronic arterial disease, and our distinct impression was that the deterioration in her leg, the acutely ischemic leg, was a reflection of her being profoundly unwell and hypertensive, and that in conjunction with her chronic arterial disease was enough for an acute deterioration in her peripheral perfusion. But the underlying problem being acute mesenteric ischemia, and the CT does not look good at all. There is mural gas you can see here in the stomach. I'm sorry, the writing's in blue, you can't read it. But yeah, mural gas, portal venous gas is seen in the liver. Gas within the small bowel mesentery, again, probably portal venous gas. So that is a horrible sign of really advanced bowel ischemia and infarction. And the CT angiogram demonstrates severe disease at the origin of both the celiac and the superior mesenteric artery with a mass of calcium there. I'm not sure if the IMA was patent, and this lady was known to have an aortic aneurysm, like I said. I'm not sure. I think what we should probably have done with this lady is being frank and honest with her and managed her palliatively from the outset with that CT appearance. of advanced, very advanced ischemia and a long delay to diagnosis. She was desperate for us to do something, so we actually, in conjunction with the general surgery, we took her to theatre and performed a laparoscopy, and it was clear that the stomach, entire small bowel, and most of the colon was infarcted, and no possibility of salvaging her. So she was managed palliatively, and you could argue that it was unrealistic to manage her surgically, or but we could maybe discuss that if you've got questions. Yeah, interestingly, you will have a stronger view about this than I do, but I have noticed that in terms of assessing bowel viability in patients with acute ischemia, I think there are recommendations that laparoscopy is not appropriate and a laparotomy is better. I mean, I must admit, we do, with our general surgeons, we do carry out laparoscopy in some of these patients, as in that last lady. But I think you have to be pretty confident that you can walk throughout the entire small bowel and not to miss segmental ischemia of the bowel. It'd be interesting to hear views on that. My understanding is it's not recommended when I last read the guidelines. But we do it depending on the confidence of our general surgical colleagues in their ability to walk through the entire small bowel, I guess, with laparoscopically. Yep. As you said before, we revascularize if the bowel looks ischemic but potentially salvageable. If there's frankly necrotic bowel, we will resect that first and then revascularize, but otherwise we will revascularize first, reassess the bowel. If it's questionable, we'll close and a second look. If they're at that stage, if it's clear what is demarcated and looks viable and what isn't, we'll do a resection at that stage. Yeah, so acute and chronic mesenteric ischemia, very difficult diagnostic problems. I think we are improving. I don't have hard data to show that. We have looked at it locally, like I said, and the quoted mortality rates of 60 to 80%, we're doing much better than that now. So it's not all doom and gloom. And I think that's probably mainly due to awareness, index of suspicion amongst our general surgical colleagues, and CT, a low threshold for most patients, I think, with acute abdomens getting CT. As we said, physical signs, especially in the early stages, laboratory tests are not helpful. We don't rely on them. High index of suspicion, early diagnosis is the key. Early diagnosis and early intervention is the key to saving these patients. Thank you very much. I think that is all I have to say. I will stop sharing my screen. And
thank you, Murray. My colleague Alison's
any questions, I'll be happy to take them.
Yeah, thanks, Murray, for that. Alison's going to run through any questions that we've had while you've been presenting.
Excellent. Thanks again. Brilliant talk. So the first question that came in asks, what are the success rates for bypass when managing AMI?
So very little good quality data on that. I can tell you more about survival after acute mesenteric ischemia. We do comparatively few bypasses in acute mesenteric ischemia, particularly the patients with emboli into the SMA. Most of them are managed with surgical embolectomy rather than bypass. The acute and chronic patients, like the second case we discussed, they are often very high risk, emaciated patients, malnourished, as well as with lots of comorbidities. So there is I think there's an increasing, certainly in our practice, increasing we push to manage these patients with endovascular means. That can be done percutaneously. If you're in our practice, if we are managing these patients with acute unchronic symptoms with percutaneous stenting of the visceral vessel, we don't have a mandatory laparotomy to assess bowel viability, but we have very close clinical observation and a low threshold for laparotomy if we're concerned about their progress. But comparatively few bypasses in acute mesenteric ischemia. So it'd be very difficult to give you, a number for success rate in that kind of situation.
Okay, thank you. Second question, can lactate be used to see or follow the evolution of our treatment?
Well, so we generally don't use it because in our experience, and I think you read this recurrently in the literature as well, lactate goes up comparatively late. We get very despondent when we see a high lactate because to us that implies that there's profoundly ischemic gut, possibly infarcted gut. So we rely on clinical reassessment of the patients, their pain, abdominal symptoms, their parameters, their oxygenation, pulse, blood pressure, symptoms, and abdominal signs. We will obviously look at blood tests as well, but we generally don't. It's clinical reevaluation is the mainstay of monitoring the patients, I think, who we are managing conservatively rather than relying on the laboratory tests.
Excellent, thank you. Someone's just asked, what are the guidelines in a setting with no immediate vascular capacity for A, bowel ischemia without necrosis, and B, bowel necrosis? We've put here bowel resection, then referral, or resuscitation and referral without bowel resection and ischemia.
Yeah, so that's a good question. So we do get referrals from satellite hospitals quite a bit. They require CT angiography at the satellite hospital before we can decide where they're best to manage. And so we will look at the CT scan. If there's a revascularization option, the patient needs to come to a vascular center. And we will discuss it with our own general surgeons, and we'll typically manage these patients jointly, make a decision if they need laparotomy, and make a decision on what form of revascularization they require. But so if there's a correctable vascular pathology, whether that's embolic or whether it's native arterial disease, we will always transfer the patients to where there's a vascular surgeon so they can get revascularized if necessary. If there is no correctable vascular pathology, if there's no, if we look at the mesenteric vessels and we say they are patent and there's no significant disease, or if there's unreconstructable disease that we cannot help with, that is comparatively rare, that second category, then we will, then it's a question with the local general surgical team of whether they think the patient is fit for laparotomy or whether that laparotomy is appropriate. But in that kind of situation, we would see no value in transferring them to us with vascular on site when there is no option for intervention from a vascular perspective.
Great,
but
thank you.
Yeah, preoperative transfer if there's arterial disease and a patient in whom there's a clinical suspicion of mesenteric ischemia, we will always ask to transfer prior to laparotomy. Because if the situation where there's a satellite hospital with no vascular on site, with a laparotomized patient, ischemic gut, then we are then potentially going to a satellite hospital with no staff experience with vascular surgery, and that is a challenging situation, I think, and is not in the patient's best interests. Does that make sense?
Yep, excellent. Final question that we have so far. Someone's asked, when is NOMI not NOMI? And they're saying, any tips for how you distinguish between true AMI and just a very unwell patient?
Yeah, so with acute mesenteric ischemia, we normally, we would see a potential cause for that, whether it's native arterial disease or embolic disease. We would regard that as an acute mesenteric ischemia. And in most of those cases, depending on the condition of the patient, there's usually something that we can do from a technical perspective to revascularize the bowel, depending on the patient presentation and or delay in diagnosis. That may not always be possible, but obviously, the sort of NOMI syndrome typically critically unwell patients in an intensive care setting that don't have any demonstrable arterial disease. We have nothing to offer really these patients from a vascular perspective. They will have supportive care if they're at all fit to consider it. They may have a laparotomy to resect the ischemic gut, but from our perspective, there's really nothing for us to offer as a vascular service. And the key is really just no identifiable cause on this CT angiogram for a patient developing arterial disease. I think a far more common scenario is people that do have significant arterial disease who are critically unwell, potentially with another illness, who will then develop acute mesenteric ischemia because of their hemodynamic compromise, but if they are suffering with a severe systemic disease, that can also be an extremely challenging group of patients to treat with a very, very high mortality risk.
Excellent, thank you. Someone's just asked, are there any guidelines that you would point the audience towards to read up on?
Very little. There's a lot of papers. But in terms, we have European guidelines, and in the UK, NICE guidelines on all sorts of aspects of peripheral arterial disease, aortic aneurysmal disease, carotid artery disease. There's no equivalent guidelines, I'm afraid, on certainly in the European Society guidelines or UK. If there are North American guidelines, they will have been published recently. I'm unaware of it, but yeah, there's very little in that regard for mesenteric ischemia, I'm afraid.
Thank you very much. Looks like the final question coming in here. They've asked for patients, for non-operable patients who can't proceed to surgical laparotomy, what's the main outlook for them?
Yeah, well, the diagnosis is correct. Diagnosis is bleak, to say the least. We do have some patients who, with so the mainstay of treatment is analgesia if we really think they're palliative, and are not salvageable. But many patients, there's a group of patients who we don't think are fit for laparotomy because of comorbidities or their general condition, but there's not definite evidence of infarcted gut. But those patients may well be treated with supportive care in a level 2 setting. Probably not appropriate for them to go to intensive care or level 3 if there's no plan for operative management. But supportive care in a level 2 setting, including broad spectrum antibiotics, analgesia, fluids, etc. A very small proportion of those patients will survive, and potentially we would question whether the diagnosis was correct in the ones that do survive, but it's oblique. In the non-operative patients, it's usually because of the severe comorbidities and or delayed presentation in a patient that we do not think salvageable, that we do not operate on them, and the prognosis is bleak, very bleak.
Excellent. Is there any role for heparin or anticoagulation in these non-operative
Yes,
candidates?
for the non-operative ones, we probably, if we think there's a potential that this might be a self-limiting episode, then yes, we will. We use low molecular weight heparin subcutaneous injections. We don't use intravenous heparin, I must admit. But yes, I think there is a place for that if we unless we are at the stage of simply keeping someone comfortable with palliative care or end-of-life care. We wouldn't anticoagulate them, but we would if we thought there was a chance that the disease could be self-limiting. And the operative ones, almost all of them are anticoagulated.
Excellent. Thank you. That seems to be all the questions that have come in. Lots of people commenting that it was an excellent talk and wanting to pass on their thanks, but no further questions there.
Well, thank you very much. Thank you.
Well, Murray, thanks very much for A, accepting the talk, and B, delivering it. It's taken us just after 3 o'clock on a Friday afternoon UK time. Just before people leave, I just want to highlight that this Sunday, TUGSS are doing a deep dive into esophageal cancer. It's 12 o'clock UK time. I think you can sign up for that. And on Monday, I'm also I've got some speakers lined up to do an emergency general surgery talk on acute pancreatitis. That's Monday, 22nd of April at 7 p.m. And then finally, we're going to do an update on appendicitis on Monday, the 13th of May. So watch out for that. And that's your next CPD events. So without further ado, I'll let people get on with the rest of their weekend. Thank you again, Murray.
Thank you, folks. Bye now. Bye-bye.